Jesus Christ.
All right, colleagues, we'll go ahead and start. Good afternoon, everyone, and thank you for attending this really very important session looking at laboratory services broadly, but also within the context of the EMTCT Plus initiative in the Caribbean. On behalf of the Advisory Committee of the Community of Practice and the Secretariat of the Community of Practice, Dr. Omar Suede and Ms. Sandra Jones of PAHO, I welcome you to this session. Before we get into the actual session again, I'll make the announcement. If participants can kindly use the chat to state your name, your profession, and your country, that would be very helpful to us. So please go ahead and do that. And so for a few housekeeping notes, please kindly keep your microphones muted and your cameras off. We'll have an opportunity during the Q&A segment for you to ask questions, for you to share your opinions, for you to provide any comments. So at that time, you will be able to open your microphones and you'll be able to speak. I will go ahead now and administer a very quick poll. Let me see where the poll is. If you can take a few minutes to respond to the questions. Valerie, can you confirm that you're seeing the poll?
Yes, I am.
Thank you. So we do have 133 participants on. Go ahead and start responding to the poll, and our presenter, Valerie and Andrea, will be able to respond to what they're seeing once you're responding to the question. So please do. A lot of the questions that I've seen in the poll, Val, are about persons' experiences in the lab primarily.
Yeah, but they're also about understanding where things apply in a wider sense.
Oh, okay. You can see as people are responding, right, Valerie?
Yes, I can.
And you can see the responses as well.
Mm-hmm. Mm-hmm.
Okay. How do we take the responses during your presentation or after?
Yeah, I guess we can do them after so that after the presentation I think everybody will then know the answers, so we could run through them very quickly.
Oh, wonderful. All right, colleagues. So keep responding to the poll. We have a few minutes for this. And as a kind reminder, kindly state your name, your profession, and your country using the chat. We have your email addresses, so no need for the email address, just your name, profession, and country. Okay, so while you keep working on the poll, let me go ahead and start introducing our first presenter, Ms. Valerie Wilson. So before I do that very quickly, we will take the two presentation, the first one from Ms. Valerie Wilson and the second one from Ms. Andrea Gale Orlue. We'll take the two presentations and then we will leave a few minutes before we close for any reactions, any comments, any questions, and our presenters will respond to those in the Q&A section. So the first presenter, Ms. Valerie Wilson, she has a master's degree in immunology and a master's in business administration. I think a lot of you may know Ms. Valerie Wilson. She has extensive experience in the areas of public health laboratory reference services, laboratory management, quality improvement, and strategic management. And she's worked very extensively in the region, providing leadership and technical advisory services to ministries of health, private and public sector laboratories, and staff in 23 countries. Throughout her work as laboratory manager and later as project manager for the European Union funded laboratory strengthening project at the Caribbean Epidemiology Center, CAREC, from 1990 to 2007. From 2008 to present, Ms. Valerie Wilson is the director of the Caribbean MedLabs Foundation and continues to do significant work across our Caribbean countries. Like I said, it is very likely many of you may have interacted with Ms. Valerie Wilson at your country level, at the level of laboratory systems, and I think more recently in the area of HIV self-testing. So with that, I am going to pass it over to you, Valerie. Let me just stop the poll.
Thank you. Thanks, Shanti.
Is the poll off? Can you share your slide?
Yes, I'm going to
Okay,
do that now. Yes.
thank you.
Okay. So thank you very much, Shanti, for that lovely introduction. And thank you to all of you for being here this afternoon. And, laboratories are sometimes seen as a sort of black box that nobody knows what goes on in there. And we're actually really happy to share with all of the persons who are here this evening. I saw a number of people who are clinicians, a number of people who are nurses. I saw lab technologists and lab managers, and others in the healthcare field. And we're really happy to share with you the whole issue of laboratories and the importance of quality, which is really the basis for diagnosis, care, and treatment. Labs are really at the base of a lot of the decisions that are made. And the labs are part of a really key pillar for the elimination of mother-to-child transmission of HIV, syphilis, and hepatitis. So I'm happy to share that with you in the context of the GVAC, the Global Validation Committee, and the Regional Validation Committee for PAHO and for WHO, on which I have participated. So this presentation, of course, is being done under the EMTCT Community of Practice, which is funded by the Indian UN Development Fund. And of course, PAHO is very central to this whole initiative. Now, at the end of the sessions, I am hoping that participants will be able to describe how testing errors can and do occur. It's really important, not just for lab personnel, but for personnel who use lab services, clinicians and others in the healthcare field, to understand how testing errors can and do occur, how the accuracy and reliability of all testing requires implementation of very specific quality and safety measures, and what are some of the challenges that we see in terms of the laboratory services that have to be overcome, not just for EMTCT, elimination of mother-to-child transmission, but also for other disease programs, because what I'm talking about today doesn't apply only to EMTCT. And of course, the critical importance of point-of-care testing to national HIV and syphilis control and prevention efforts, and the need, again, for rigorous quality oversight in that regard. So the first point that I really want to make with the first few slides is that laboratory quality really impacts people's lives. And this is something that sometimes, I think, sometimes even those who are working in the lab don't think about really, because they're faced with 150 tubes of samples to test in the day, and perhaps they're not thinking that every single one of those represents a person who has a life, whether, and how the lab test actually impacts on their life. And we really know that there is nearly 70% of diagnostic errors occur during testing. So this is really why testing is so important, for us to recognize that testing is really a fundamental part of what leads to medical error. And in fact, diagnostic errors were generally identified to be due to referrals, communication. And there was a major study done by the Emergency Care Research Institute in 2024, and these are the results that they had come up with, that nearly 7 in 10 errors occur during the testing process. That is phenomenal. That is really very, very significant. And they organized more than 3,000 patient safety adverse events and near misses that were reported by healthcare workers. And of those errors, more than 23% were due to a technical or processing error, such as the misuse of testing equipment, a poorly processed specimen, or a clinician or tester lacking the proper skill and to conduct the test. So fundamentally human error. Poorly processed specimens, things not being done right, persons not adequately trained, etc. So it's really, really important. Of those errors, 23% were in that area. And another 20% were a result of mixed up samples, mislabeled samples, test performed on the wrong patient. Again, a lot of human error that we can see is happening here. And then 12% occurred in the monitoring and follow-up phase, and about 9% happened in the referral and consultation phase, including miscommunication. So communication is really a very critical part of the whole process that takes place in the lab. And sometimes we don't think much about it, but in fact, in order to do a test, there has to be communication. Even though it's on a piece of paper, it's really important, or in a computerized system. It is really important for the laboratory to have information in order to actually produce the outcome. And we all have to remember that the outcome of laboratory, it's not just about testing, it's about information, because that is what the clinician needs. That's what he needs on the other side to be able to make decisions about what is happening with the patient. And lab errors occur very widely, and you can see from some of the data that is presented here, just some examples that you can find from media reports even about lab errors. A blood test was blamed for a catalog of disasters in 2025. This is quite a recent situation reported by the BBC, that an NHS and National Health Service provider had won a £2 billion contract to deliver blood testing services, and it was failing to deliver reliable results according to the medical professionals. And unreliable results with erroneously high potassium levels cause a lot of persons to be diagnosed with potential heart disease. And of course, the whole reason for those high potassiums was the processing delays, which of course affected the potassium levels in the samples. So this was a regular occurrence that was reported in the BBC. Another example here is where a high court in Uganda actually awarded 190 million shillings in damages to a patient who was incorrectly diagnosed with HIV and placed on ARVs for 7 years. He actually took ARVs. It seems amazing, I know, but we may have examples that happen here in the region as well, because lab error is very, very real. And this again was reported again in a newspaper, an online newspaper. The UK Health Services Agency published the investigation findings following errors. A private lab that was commissioned to provide additional testing capacity during COVID, and they actually identified that around 39,000 results for PCR, which we all think is absolutely, the ultimate in terms of testing. And they actually estimated they had 39,000, 10% of samples being incorrectly reported as negative when they should have been positive. Again, and this was a press release by the UK government themselves. In Charlotte, in the USA, there were DNA issues with DNA testing, where the lab analysts used a positive control when actually doing patient samples. And of course, this led to errors in DNA testing. And DNA testing, it was a crime lab, was actually being used in rape and murder cases. 2024. So these things are happening very present. These are not old situations. These are very current situations in environments where generally there's a lot of regulation. So we have to understand in an environment where there isn't regulation, this could be much greater in our environment. Diabetes, another one of those very simple tests, blood glucose that we think, it's simple. When a particular machine that was used to diagnose 55,000 people in England will need further blood tests. A BBC investigation discovered some had been wrongly diagnosed with type 2 diabetes and even prescribed medication. So these are the realities. The patient is who feels the brunt of these circumstances, of course. But of course, the lab and the personnel in the lab, and if it is run and overseen by a clinician, they all have to answer for the situations that arise. And in one case here in 2001, CBS actually reported where two patients had died in a medical center because the blood sample results for 932 patients were improperly calculated. And so the patients received incorrect doses of anticoagulants, and two of them died of intracranial hemorrhage. So the reality is very present, and we need to understand that lab error is a very, very real possibility. And so even as we look to how we control things in the laboratory, it's really, really important for us all to be very aware of that, whether we are the users of the lab service or the persons who are actually providing the lab service. And the cause of clinical laboratory errors, this was a recent study done I think this was in Thailand. Yeah, it was in Thailand. And they actually found that human error, and that was one of your questions, human error actually accounted for the majority of the causes of errors, and in fact, human error in the pre-analytic phase. Just as the emergency services study that I showed you earlier reported that you had human error, and in many cases, it was in that pre-analytic area where you actually have to make sure that you do the right test, make sure that the right test is ordered, because even there, errors occur where there is over or underutilization of tests and requests are not actually consistent with what is required as an outcome from the laboratory. Technical error was much lower, as you could see, 86 of the total, 8.3%, but the human error was up at 91%, and organization was way down at 6%. So the most common error subtypes here were incorrect test ordering, and I really want us to focus on that because sometimes we don't think there's any problem at that end, but there is a major problem. It was 48.2% of the incorrect, of the errors that arose were incorrect test ordering, and specimen collection was at 34.6%. So diagnostic errors in clinical testing are very real, and they impact very significantly on patient safety. So it's really, really important for us to remember that and be always very aware of that as we look at what's happening with our lab testing. So lab testing is a complex process. We think it's very simple. Generally, people think it's really simple. It is a complex process. It's like a production line. So you have the pre-analytic area, which involves the test ordering, the sample collection, the transport of the sample, if that is necessary, and the sample receipt and processing at the front end. And then you have the analytic processes, which take place, and that is about the actual testing that takes place on the bench, the quality control, the results review, the follow-up, the interpretation, all of that is, and quality control here also includes doing your external quality assessment. And The final one, post-analytic, where you're dealing with the result reporting and archiving, the sample management, getting those results back to where they are needed in a timely manner. All of these are areas that are quite prone to error and can result in error, as you would imagine, given the kind of process that is involved. So there's significant potential for client harm in the pre-analytic area, and that's for all tests, regardless of whether they're rapid tests, PCR tests, tests that we do every day, those sort of bread and butter tests like the chemistries and hematologies that are done very commonly with the big analyzers. Poor sampling technique. If we don't take the right sample, we have had situations where people, of course, and we know this happens, take the sample in the wrong tube, and if the lab doesn't pick it up, they test the wrong tube. And that may sound like it's not a big deal, but of course it's a big deal if, in fact, you must use a sample that has EDTA rather than heparin, and you use EDTA instead, because the tests are equilibrated and they are established with those requirements. You can have compromised or spoiled samples, and often, this is one of the ones that I think often causes some conflict between the lab and clinicians who may be requesting a test, and the sample has stayed along too long, it got to the lab too late, it got to the lab, when I say too late, not that it's late for the lab, but it is late for the sample in terms of providing a valid result. And this is something that, is a requirement that labs have got to oversee and meet in order to make sure that the clinician can get a correct result. The transportation, of course, is really critical. Sometimes samples in our part of the world drive around for hours in a hot vehicle. That can lead to lots of errors. Transcription is also a major source of error. Anybody who has had to write a lot of numbers, write a lot of information would know how easily transcription errors can arise, whether they are being typed into an electronic system or they're being written by longhand. Transcription error is very, very real. And this is why a lot of the information systems that have been developed for laboratories have moved to using barcodes so that it eliminates, to some extent, not totally, of course, but to some extent, having to transcribe long numbers, etc. Of course, that leads us to data management, and of course, things like giving the right result to the wrong person or the wrong result to the right person. If we start off with a sample mix-up, no matter how well we do the test, if Mr. Smith's sample was tested instead of Mr. Jones, Mr. Smith will get the wrong result, and so will Mr. Jones, because their samples have been mixed up. We can't get it right if we start with the wrong sample. So we end up with wrong treatment, increased mortality and or morbidity, and negative social implications for the client, depending on what the test is. But certainly morbidity and mortality are major cause for concern. Where we give someone wrong treatment, think about the man who was put on HIV medication for how many years, the patients who were put on warfarin when they didn't need it, or maybe didn't need such high doses, and ended up with intracranial hemorrhage. So these things are really, really, really critical to ensuring the adequacy of our lab results. All tests, including rapid tests, so regardless of whether they are those tests being done by big analyzers, by a PCR, analyzer, whatever it is, or a rapid test that you do on the desk, the verification is really, really important. We must verify that the test is actually working. All this is part of the standard requirements for labs. The quality control is critical, must be done all the time, every day. The technique in terms of competence, are persons competent to do what they are doing? That is a very, very critical part of the whole process, as you would imagine. The methodology, is it a correct methodology for the purpose that we're using? And you can, in fact, introduce incorrect methodology or utilize incorrect methodology to produce the outcome that you are trying to achieve with the lab testing. You have malfunctioning equipment, of course. We are supposed to be able to detect that by the ways in which we control the equipment and do maintenance, preventive maintenance every day on those pieces of equipment so that we can make sure that the equipment is functioning as it should. And of course, the calibration is a key part of that. The quality control is a key part of that. If we use expired reagents or spoiled reagents, sometimes, again, clinicians might say, well, you can use the reagents even though it's just, recently expired. But then there's no guarantee that what you get is going to be correct. So managing, how you manage your reagents and supplies is really a key part of that. External quality assessment, and Andrea is going to be talking about the external quality assessment program in Jamaica for their rapid testing sites. And participating in EQA is important, not just for rapid test sites, but for all testing that is done in the lab or out of the lab, whether it is at a rapid testing site. EQA is a fundamental part, external quality assessment. And of course, the interpretation, with whether you get a wrong result or you have the wrong interpretation of the result. Sometimes a test can seem very simple, and yet you get the wrong interpretation, resulting again in the same things that we talked about: the wrong treatment, the increased morbidity and mortality, and negative implications for your clients. And then finally, in the post-analytic area, and it's really important for everyone, for all of us to understand each of these areas have their own susceptibilities to error and potential harm for the patient or the client. Again, loss reports, things, we know that this is one of the things that happens a lot where reports are being sent, hard copy especially, and they're lost. There may be mixed up reports where an individual gets the wrong result, incorrect results reporting, and delays. Delays are one of the big issues, of course. Incorrect is the most critically important one of these listed here: incorrect results and mixed up reports, etc. But delays in result reporting can delay in providing the treatment that someone needs very urgently to ensure that they are treated appropriately. The lack of confidentiality, of course, is one of the major things that impacts here, and it impacts all the way through, actually, from the beginning to the end of the lab process. The record keeping and data management. If our record keeping and data management are not as they should be, we do not know at the end of it all. If, for example, a lost report happened and you wanted to find out what that report was previously, you can't find out because data is not being adequately managed. So all of this leads to client frustration and, of course, loss of trust, and again, wrong treatment and increased morbidity and mortality. So, and I want to thank my colleague, Wendy Kitson-Piggott, for this slide. It's really a slide that really tells us the diagnostic harm and how we can actually deal with them. So once you have an unreliable, what happens? You have an unreliable test result where you have a false negative or false positive, and this is really done for rapid tests, but it applies to anything. So if you have an unreliable test result, you had a problem in one of those areas, the pre-analytic, the analytic or post-analytic area, the end result is, your result is incorrect. And therefore, the clinician who is relying 70% of these errors that arise in the clinical environment are caused by lab error. So the clinician is relying on that result to make a decision. And of course, he acts on an unreliable result, just as happened with the examples that I gave you earlier of potassium or other kinds of HIV, etc., diabetes testing, etc. So you have delayed or mistreatment, or you have overtreatment for that matter, which is what happened in some of those examples that I gave you. So you have not only time loss, but sometimes you have because of excessive amounts of treatment, you have patient harm. Your patient is harmed either by not having the treatment he should have or having more than the required treatment, and it causes harm maybe to others in the community. If, for example, the COVID example that I gave, where people got negative PCR results when they should have got positive, and therefore they would not have isolated, they would have spread the infection, and so significant harm to the community. If you do a wrong HIV result and someone is positive, they get a negative result, you get again, the potential for harm to the community. So this, of course, builds to system and economic impact and a loss of trust in the health service, of course, because nobody wants to know where things went wrong. They just think they got the wrong treatment. And at the end of it all, the outcome is the same. The health service is not trustworthy, regardless of whether it is the clinician, the lab, or someone else in the process. So we need to break the cascade at the source, use quality tests, control the conditions under which the test is done, follow the process very, very carefully, and ensure that quality control, external quality assessment, all of those things are done. Invest in people in terms of training personnel so that they are exhibiting the kind of competence that they need to have. And of course, you need to monitor and improve all the time as we go through this process of lab testing. Monitoring and improvement is a very, very, very key part of this whole process. And of course, communicating and following up. So as we kind of focus in on EMTCT and we start talking about HIV and syphilis, let us just look very quickly at some of the rapid test algorithms that we use. The testing algorithms are a result of the fact that no single test for HIV or for syphilis, for that matter, can diagnose and confirm. So a combination of tests, which is an algorithm, is necessary to confirm. And the algorithms have to be validated for the environment in which they're being used, whether nationally or regionally, they have to be confirmed. So it's not just pick up any test. That's one of the problems that we often have, that people don't always understand that, in fact, it is necessary to verify the tests and to verify the algorithm. So both things at both levels. So the test itself, and then the combination of tests that gives us an outcome that we can rely on. So when we look at, for example, what we call a serial test algorithm for HIV, we have a blood sample, we do the first test. It might be non-reactive or it might be reactive. If it's non-reactive, we interpret it as negative. If it's reactive, we do a second test. So we only test the second test if the first test is actually reactive. So this is where the second test comes in. Once you have a reactive first test, if it's non-reactive, it's negative, and that's it. So once you have that second test, then you have two options again, whether it's reactive or non-reactive. If it is reactive, then you interpret it as positive. And if it is non-reactive, because you had a reactive in the first test and a non-reactive in the second test, these are discordant results and they need to be taken on to the confirmatory level. And if at the confirmatory level it comes up non-reactive, then the interpretation would be negative, because you had a reactive initially, non-reactive, and then negative, non-reactive again. The reason why a reactive may, in the end, a reactive in the first instance may eventually turn out to be negative is that in the algorithm, when we set up algorithms, we set them up so that the most sensitive test is used first. Why we do that? Because we want to make sure that we pick up any possible reaction. So it may err on the side of giving you a reactive even where there isn't actually antibody to HIV. So that is the reason why we try to use that very, very sensitive test first, and then we follow it with a more specific test. That's how the algorithm is set up. You don't need to understand all of those details, but that is actually how we work to set up an algorithm. If, in fact, at the end of it, you find that you get a reactive on that third test, then you interpret it as positive. So you may get a negative or you may get a positive depending on the outcome of that third test. There's also parallel testing where you can test both tests at the same time. I think somebody's pen is writing on the slides. So the test 1 and test 2 are done at the same time. So this is what a parallel algorithm means. It's different to a serial algorithm where you do one test and then depending on that result, you do the second test. In a parallel algorithm, you're doing both tests at the same time at level 1 at the clinic. If both are non-reactive, then you report them negative. If both are reactive, it is actually indicative of positive, and depending on how your algorithm has been set up, you may forward it for confirmation. If it is one reactive and one non-reactive, you have the same situation that you had earlier with a discordant, and you have to send it for the third confirmatory test. If it comes up reactive, you report it reactive, and if it comes up non-reactive, it's reported as negative. So a slightly different way of doing it. This parallel algorithm is actually usually a bit more expensive to run. And so generally people try to go for the serial algorithms if in fact it's possible to find a serial algorithm. The syphilis test algorithms are more complex in some ways, and the original syphilis test algorithms use the non-treponemal tests as the first test. And those were tests like RPR and VDRL, which all of us would have known about for many years, and they would give you a titer, really. But they're not actually used at point of care. So they have to go to the laboratory. And if they are reactive, if the initial test is reactive, then a quantitative non-treponemal or treponemal test would be done, and to see whether it is reactive or non-reactive. At the end of it, you still have to understand the clinical situation in order to interpret the final result. Because if you got this kind of reading where you got the qualitative non-treponemal test reactive and then the quantitative non-treponemal test and then reactive, it would be consistent with current syphilis infection. If it was non-reactive at this stage, then the syphilis infection is unlikely because here you're looking to see the difference between the treponemal and non-treponemal test. And if that non-treponemal was non-reactive, there's no laboratory evidence of syphilis. Again, the algorithms are important. The lab personnel must follow, and the personnel who are testing must follow the algorithms in order to give the clinician an outcome that he is able to interpret. If people change algorithms, then in fact, it changes entirely what the meaning of it, of the outcome is. So for example, there is a syphilis reverse sequence algorithm that has become much more the way in which testing is done now. And the treponemal immunoassay is used at the point of care. So this allows women to be tested at the point of care. For example, pregnant women who come in and may have syphilis, one of the tests that is done for pregnant women, especially if a woman shows up late in her pregnancy, and you need, as you all know, to give her the medication for syphilis at least a month before the delivery of the baby to prevent congenital syphilis, then this treponemal immunoassay at the point of care it's a rapid test, becomes very, very important to be able to use that in order to identify if the woman may have antibodies to treponemal. And if they're reactive, then you send it into the lab and look to see whether you get a reactive or non-reactive, etc. The same basically the same algorithm, but in reverse. And one of the really key things here is that if it is reactive, you can, in fact, and in fact, WHO has recommended that the outcomes of course, potential syphilis to the baby, especially if the woman presents late, is much worse than giving her the dosage of penicillin that is required to even if she doesn't have active syphilis, because that's the point. What happens with these immunoassays is that they remain positive for life, as opposed to the non-treponemal assays that will actually give you reactives only when there is some current infection. So these are the ways in which you can differentiate to some extent between current and past infection, but syphilis is not really a lab diagnosis. It is actually a diagnosis that very much depends on the clinical situation, the history of the patient, etc. If that treponemal assay at the start here was non-reactive, then it means there's no lab evidence of syphilis infection. So this is the best possible outcome, of course, and you don't have to go through all the other stages of the algorithm to see if the patient may have syphilis. So I really wanted to just mention these algorithms because it's really important for every clinician to recognize and understand what you're actually being given when you are given a measurement from the laboratory when it comes to anything for that matter. But in the case of HIV and syphilis, this has illustrated for you how much goes into what you actually receive at the end of it all. And likewise, you may have other processes that arise for PCR, for other immunoassays that may be done otherwise. So clinicians really should ask some questions. Does the result fit the clinical picture? If it doesn't, maybe you need to confer with the lab in terms of what may have transpired or what may be the reality of the situation. Was the specimen adequate? Was the timing of testing appropriate? Could a window period apply to this disease? And we have window periods for HIV, for example, for all the infectious diseases. In fact, you have window periods. Could a window period apply? Was testing of the QC acceptable, the quality control? Was confirmatory testing needed and conducted? Did you get a result that was a screen reactive that was reported as a positive? Or was the confirmatory test actually done on this particular patient? Could another condition interfere with this test result? As happens in the HIV antibodies, you might have antibodies to systemic lupus that might interfere. You might have, in the case of syphilis, yours that might interfere. You could have malaria with HIV. So there are a number of things that could interferences that you can have. And what potential harm could occur from the wrong result? And therefore, do you need to repeat? Do you need to relook at what is happening? If there's a potential window period, do you need to test again at another time? So there's a lot that goes into this, and it's not just a straight, I put this into the black box and I get an answer out of the black box and I go ahead and deal with it. Just to end, I'm going to go through the key requirements for EMTCT certification of laboratory services. And just to remind us again why testing systems fail. Testing systems fail because the part that you see is the test request and the test result. So that's the part that you see. You don't see all of the system that sits behind the test. So it's like an iceberg. You see like the 10% that is on the top and you don't see the 90% that is under the water. And remember what the 90% happened? You know what happened with Titanic, right? It was the 90% that actually caused the boat to sink and fail. So when you have all of that hidden part under the test, the outcome of the test is really only as good as all of that is. The quality of the test, the reagents, the sample, the procedure, the training of the personnel, how they manage the information, etc., to make sure that the documentation is correct and there's no transcription, etc., etc. There's a lot that goes in underneath every single test result that you receive. So good testing is actually much more than what you see at the surface. It is really fundamentally what you don't see under the surface. And, in the case of EMTCT, of course, you have an opportunity to treat women and ensure that their babies are born free of HIV or free of syphilis or free of hepatitis B. And so the timing is really important. The linking them to care is really important. Making sure that they are actually treated early is really, really critical. And then, of course, following up to make sure, because if you act early and act today, you can actually protect 2 lives. And the bottom of this slide actually illustrates the point about the window period. I think one of the questions that I asked was, are the tests that we are using to do all these rapid tests now so good that the window period is no longer an issue? You can see from the way that this slide is showing you, when we had, for example, the HIV antibody test, the window period really ran until somewhere around 2 to 3 months. Now that we have the HIV antigen antibody test, but you have to ask what test is actually being used. If you're using an antigen antibody test for HIV, where you have antigen as well as antibody being measured, then your window period actually is about a month. So it is shorter, but there is still a window period. Window period meaning this is the period of time when the test is not sensitive enough to pick up anything that you may that the patient may be showing in terms of actually having the infection. The antigen level may be too low, the antibody level hasn't risen yet, and that is why there's a window period. And similar things arise for syphilis, hepatitis B, and hepatitis C. So that window period exists for all of these viral infections. It exists for all viral infections. It exists for dengue. It exists for, and this is why for all of the viruses, the influenza, etc. And this is the reason why PCR testing or molecular testing has actually become, sort of very commonly used for diagnosing those kinds of infections, for COVID, for example, etc. The problem, of course, is that those tests are much more labor-intensive, costly, requiring of more expertise, etc. And this is why the rapid tests are really so useful. So the specific testing components for mothers and children, of course, we do serological testing for HIV, syphilis, and hepatitis B, according to the algorithms, the verified algorithms. We do virological testing for HIV and hepatitis B, viral load. We do HIV virological testing for the infants, the early infant diagnosis, and syphilis testing for infants, including stillborn infants, needs to be done. And of course, we need evidence of external quality assessment and other quality management systems for all of these various tests that we're doing. So not just the rapid tests, but all the tests. So whether it is a virological test, which is a PCR test, or a molecular test, we need to have all of these quality systems and the external quality assessment for them. So the laboratory services under EMTCT require a significant, assessment. It draws on the PAHO guidance on conduct of laboratory audits, the laboratory quality improvement and accreditation guidance from WHO, and of course on the international standard, which is agreed all throughout the world, the ISO 15189, which is the medical laboratories requirements for quality and competence. So when we are looking at elimination of multi-trial transmission, the lab service requirements are really very critical. There are 4 pillars, and the lab is one of the very critical pillars. You The labs contributing to the EMTCT must have a quality management system with supportive leadership and governance. But if you think about it, this is not just for EMTCT. This is really what you require for any kind of testing that is being done. The quality of the test kits and procedures to make sure that you are procuring with and storing according to the requirements, ensuring that the personnel, if you have competent personnel doing the testing, that you're using algorithms that are nationally recommended and approved, and that you have external and internal quality control, external quality assessment and internal quality control at all levels, not just at the main hospital lab, and a data management system that in fact ensures that the data is managed as it should be. So that validation really includes the external quality assessment, the implementation of that standard, and the review of all the testing of, not all, because selected sites and labs are reviewed as part of the laboratory quality assessment. And when we talk about lab quality management, what are we talking about? The general and organization and functioning of the program with the leadership and governance, the national lab policy.
And now it's negative because of...
Hello?
Sorry about that, Valerie. Continue.
Okay. The structure and coordination and management and supervision of that national lab network. It's really fundamental to the EMTCT that the network should be coordinated. It's not that everybody's off doing their own thing, using their own algorithms, testing in any way that they feel they should. And then you have the service delivery, where you are looking at the roles and responsibilities, the quality control and the quality assurance for the testing. And of course, how you are managing your supply chain in terms of making sure that you have materials to do what you need to do. The quality of test. So apart from the quality of testing, which we'll talk about next, the quality of tests, you have to ensure that you're using WHO or other organization, relevant government approved testing, so that test kits that are not just a test kit that somebody might be producing in their garage. You want tests that are approved by regulatory agencies, and we tend to use mostly WHO pre-qualified tests. The national verified algorithms, we talked about that already, for HIV, syphilis, in accordance with whatever is nationally verified. So that is a very important, and with guidance from those international agencies. And of course, the tests that are suitable for maternal and child health. So for example, for early infant diagnosis, we use a DNA PCR because we are trying to ensure that what we're actually measuring is the virus in the baby, and certainly not the mother's antibodies. In terms of quality of testing, we need to make sure that personnel are competent in terms of ensuring that they have their licensure, if there's such a thing at national level, that they've been appropriately trained, so they are qualified, and then that they are competency assessed. So qualification and competency assessment is not the same thing. When we say we hire technologists who are experienced, we're not talking about competency assessed personnel. This is what you require for ensuring testing competency. And of course, that means that the staff are proficient in performing the tests that they are responsible for. And finally, the data management system really requires an information system, whether it's manual or electronic. The important thing is that it must provide timely results so that babies and mothers can be treated in a timely manner. So some of the challenges that we've observed in doing the lab validations in the Caribbean, we've seen national lab policies that have been in draft for many years. We've seen insufficient quality management systems implementation unclear or incomplete algorithms, variable implementation of algorithms. I talked about the fact that the algorithm must be followed, but sometimes you see that syphilis algorithm is not completely followed, or an HIV algorithm. They switch around the tests. You can't switch around the tests. You have to run the tests as they are prescribed in the algorithm, or they get a donation of tests that is not anywhere in their algorithm, and that is in use. We have seen point of care tests not used appropriately, like they are used in the labs only instead of being used at the point of care where women may be coming in late or they might be in a very remote district. These are really, or they present at labor. So this is really, really important. Extended turnaround times. This tends to happen a lot for things like viral load and early infant diagnosis, because those are PCR tests that are more centralized, but it is very important to get timely results. The performance of EQA at all levels, and Andrea is going to be talking about that, because the EQA can't be just at the national lab, because all these testing sites and other places are testing the women and others. All kinds of testing is happening in other places. So an EQA program is not just for the national lab. The supervision and monitoring of the sites, and Andrea will talk some about that as well in terms of how the supervision and monitoring of testing sites. And then, of course, the issues of stockouts. So we know that this is sort of a major issue within our region, and we really need to deal with that. So some of the key issues, this is just talking about EMTCT and what actually happens, that there's a committee that requires experts in each area, and there's crossover among team members, and the data from lab, for instance, influences program, because the program is looking to see how timely is the woman being treated, how timely are they in identifying if the baby has been born free of syphilis or free of HIV. And the program and data really interact. So they are not unique. They cross over, and therefore the team members need to integrate in terms of supporting elimination efforts. And of course, the in-country reviews are quite extensive. They involve hybrid, sometimes online and then in-country. And in small countries or women with low numbers, pooling of data is acceptable. So data might be pooled for 5 years or 4 years, as the case might be. And for larger countries, with high burdens, they would actually take a stepwise process so that they could actually, over time, actually eliminate. So critical success factors, country commitment at all levels, including the political level, is really fundamental. A clear understanding of all the technical requirements, teamwork among all the sectors, the program, the data, the human rights, and consistent implementation and monitoring, the data collection and analysis. But as you can see, this really applies beyond EMTCT. So EMTCT has really motivated governments to 11 countries in the region have been validated, and there are only 19 countries internationally. So that tells you how the Caribbean has been moving in this area. Excellent movement. And the high level of government engagement has really facilitated changes that were delayed for a number of years. Some of it related to books criminalizing sexual, laws criminalizing sexual practices, and adoption of those national lab policies that were sitting, unadopted for years. And those health system improvements, and particularly as I am speaking about the lab improvements within countries that have achieved and maintained validation, are really critical to not just the EMTCT program, but way beyond the EMTCT program, as you can see. And of course, that improved teamwork that has been engendered through EMTCT has also got its really important place in a national sense beyond EMTCT. And in some cases, countries have actually introduced electronic systems to monitor the key parameters around testing for pregnant women. And some of those systems have, of course, extended beyond pregnant women. So I will end here, and thank you for your attention.
All right. Thank you very much, Valerie. I can ask Andrea to go ahead, put up your presentation. Thank you very much, Valerie. I thought that was really very, very comprehensive. Starting out looking at, what did you call it? You called it the pre-analytic, analytic, and post-analytic stages. And some of the errors that can occur at the different stages. I thought it was interesting that more than 80% of it are actually human errors, and a lot of it occur in the pre-analytic phase of this. So
Yes.
that was and meaning that it could potentially be corrected with a little bit more diligence, attention
And
to
training
detail,
and
training.
monitoring. Yeah.
Correct. So thank you. And then I think also nicely taking us through, navigating us or transitioning us from that big picture to EMTCT and demonstrating how EMTCT has also advanced laboratory services. Andrea, are you getting through?
Yeah, because we saw your slides just now.
Yes, I'm trying to set up. I forgot to unmute.
Yeah.
Okay, but your slides were up,
They
right?
were up, yeah.
Right.
Just
Now
go on slideshow now.
Yeah,
All
just
right.
one slide. Right.
All right.
Great.
Yes. So I think one of the things that you spoke about, Valerie, is the importance of having quality testing. And so let me ask Andrea to go right into her presentation and talk about their external quality assurance program in Jamaica.
Thanks, Shanti. Good afternoon, everyone. I'm Andrea Orlue. I'm the Laboratory Quality Assurance Coordinator for the National Lab Services in Jamaica. Right? My office is situated in that lovely blue and gray building you see there, where I oversee some 18 laboratories, 3 other technical departments, such as the specimen reception and accession, specimen collection, and the media prep areas. And then, of course, we have the support services. So it's a really big responsibility. But on top of that, I'm also the quality person, the quality assurance coordinator for all the regional hospitals and health center labs and the rapid HIV and syphilis testing sites across the island. It's a lot, one person. All right, so let's move right into EQA. From where I sit as the quality assurance coordinator, I oversee several EQA programs, maybe as many as 15. I think we're up to 15 or 16 now. But for today, I'm just going to speak to the HIV and STI related ones. So yeah, as you can see on the screen, the one word accuracy, if we have some lab people joining in, they may be familiar with that PT program. It's very popular. And so we do HIV, several labs are part of that program. We do CD4, VDRL and TPPA for syphilis, hepatitis B. We are the reference lab for Hep B for the public sector. And of course, can't forget herpes and gonorrhea. And those tests are all part of our EQA program. The CDC has 3 PT programs that we participate in. There's one for syphilis, one for early infant diagnosis. That's the one that they use the dry blood spot samples for the babies. And of course, viral load. We have 2 major labs, one in Kingston, my lab here, and one in Montego Bay, Cornwall Regional Hospital lab. We provide viral load testing for the island. The National Microbiology Laboratory at the Public Health Agency of Canada also provides PT for syphilis, VDRL, TPPA. For quasi, that's the CD4, the lymphocyte enumeration, we have 20 sites across the island that participate in that PT program through me. And also, the one I think I'm most proud of is the one that is totally coordinated here at the National Public Health Lab. From the making of the sample panels, distribution, the analysis of the results, and the preparation of the final report. All right, so Valerie spoke in depth, so maybe you don't need this slide, but what is EQA, External Quality Assessment? There are two types. There's a proficiency testing where the samples come from an external provider and the results are known only to them. The labs then will test and submit their results, and the provider will do thorough comparison against what is the expected result, as well as compare the results among similar labs using relatively similar methodologies and reagents. And for those who can't afford the PT from abroad, usually there's intra-laboratory comparison that you can do, where two or more labs test the same samples using the same or similar methods, and then the results are compared. Both are vital for assessing lab competence and validating the test methods being utilized. For our rapid HIV PT program, the dry tube sample method, currently have 53 labs, health centers, and even a few non-governmental organizations that are enrolled. So the first thing we do before we start making the panels is we sit and decide what will the next panel be like. We know it's going to be 6 samples, and we look back at the previous challenges and say, well, there was an issue picking up the weaker positive, so let's put one in or so, and then we determine what we call the sample order, and then we give it a PT code. The PT code is simple for us here. It's a method I actually inherited from the previous coordinator, where we just use a year and the next letter of the alphabet. So 2025 in December, we were at 2025 W. So now we are at 2026 X. The labs and the participants, let me not say labs, because not everybody has a lab. We put them by region. There are 4 health regions in Jamaica. So depending on the region, you'll get a code. So SE, as you see on the screen, that's Southeast. And there's also Southern, which is SR. There's Western, which is WR. And there's Northeast, which is NE. And the number you get is the next number in the sequence when you enroll in the program. And that lovely lady there, that's Mariah. She's one of my dear assistants who helps with the production of the sample panels. All right, so we're going to look at the actual preparation of the panels. Each package contains 6 samples, the DTS, 1 tube of the buffer, instructions for testing and submitting results, an actual sample result sheet, PT code slip. That's a little slip that says the actual PT code, the sample panel, like for instance, the one that's running now, 2026X, it would say 2026X01 to 06. And then it would also give the submission deadline. I had to put that in because a lot of the sites were making errors. Some of them did not even know their site code. So I put that there to help them. And I'd like you to just watch this little video that my team
Hello,
made.
everyone. So this is a part of our DTS program. What's taking place here is our medical technologist. We're actually doing screening for all our samples before the panel is made. So we use both Determine and the Unigo. These are the positive and negative controls that are used. Also pipette, labeling, your biohazard bag, and so forth. From this stage, we then go into preparation. So we would use a green dye. It helps to allow the pellets to be seen from the tubes. So that's the final product. That's what it looks like once it's finished. From there, also make up PBS buffer. which PBS buffers use to reconstitute the samples. From there, we would make the labels. All labels are made based on the 6 panels, each of them labeled 1 to 6 and their code, and final products are placed in biohazard bags. And this is how they look. However, it's not finished. We now go to the instruction sheet and the result sheet, along with the 4 regional health authorities, starting from Southeast Regional, Western Regional, Northeast Regional, and Southern Regional Health Authority. After all paperwork is completed, folded, then they're placed into their biohazard bag with the instruction sheet and sent to their respective care sites where they're collected, and the results would now go back to the laboratory coordinator for quality services.
All right. So that was Cindy. She mentioned that there are a lot of quality checks along the way because we want to ensure that if we say it's 3 positives and 3 negatives, then there are actually 3 positives and 3 negatives in the package. So they do their blind testing. Because HIV and blood bank are a part of the PT process, we mix the samples up so they don't know what is the order, and we just send them out and have them test as well as have a couple people pull some random panels and test the samples on the determine and the Unigoal kits. This is just a video, HIV. They insisted that I show this video. So I'll just show a little bit of it. Right, so that is one of the 3 Abbott architect analyzers that we have here that we use to do HIV testing. We also have 2 Abbott alinities over at the blood bank. And we have PCR machines I'll mention later. Rapid HIV testing and CD4 testing is also done at what we refer to as our emergency laboratory. This is a small laboratory that operates 24/7, 365 at the Kingston Public Hospital, which is just down the road. So when we close off at 4:30 here, they will go on and on. Even during the hurricanes, whatever is going on, the emergency lab is constantly going. So for the analysis of results now, when they test, they are supposed to fill out this results reporting form, and they have to give me all this information. I take off marks if even one blank is there, right? And some of the sites are in some really rural areas. So I work with them. I say, by any means necessary, get your results to me. So they'll send by bearer, I get by fax, I get by email, I even get by WhatsApp, right? It's scored out of 100, 10% of the score is for documentation. They have to fill out everything just as they do in their logbooks, which I'll show you in a minute. And 90% goes to the technical area of testing, which is, do they use their controls correctly? As Val spoke about, you do the screening kit first, and if it's negative, then you report. If it's positive, you move on to the next one. So they have to follow the national algorithm, or they'll get what we call a fat 0. Right. After all of that, at the end of the testing period, at the cutoff date, I start now analyzing the results. I used to do everything manually. So that report on the left, I used to type one each for each site. But now we're moving in the towards the electronic PT platform, which was donated to us by the CDC. It makes it so much easier. We just make the panels, send them out, they upload their results, and then when I say go, the website does all the analysis. After all of that, I prepare this summary with all the sites and their scores. Of course, because I'm so pressed, I color code everything so that at a glance, I can just pinpoint which sites need some sort of intervention, right? So we monitor over time to see if the grades improve or if they keep falling off. That would mean I have to get up, get in my car, take a drive down, and do some sort of intervention. But I must say, when I do this report, if you look closely at the bottom, you will see recommended corrective actions. So I will look at where was the issue and then recommend some form of corrective action they can do on their own. All right. How do you ensure quality zone? Valerie spoke about this. You first have to start with well-trained analysts. We have a train-the-trainer program. I think I was on one of the first. That's where I actually met Valerie in Trinidad back in, I think it was 20, can't even remember, so long. But yes, so we do the trainer, and then they do tests and a lot of other stuff to prove that they are master trainers, and then they are certified. Then these master trainers now go back to their regions and pass on the knowledge that they get. And then those testers now will get their certificates as well. It's all well and good you have well-trained testers, but if they don't have the proper resources, then it makes no sense. So what we have tried to do through the help of the CDC is to provide standardized documentation across the testing sites, or the majority of them. So they get this giant HIV and syphilis logbook where they have to collect all the information regarding the patient, who requested the test, the results of the controls, even the temperature of the testing area, because that's very important. If you do testing in an area that's too hot, a lot of people will know you can't rely on the results that you'll get. We had strong sponsorship again for reagents and supplies, but that ended last year. So if anybody out there is nice and rich and would like to donate, I would be most grateful to accept. For the test kits, we have a program here at NPHL where we validate kits, and so far we have 2 in our national algorithm, and they provide those kits. That's to standardize it and to try to prevent stockouts. Valerie spoke about competency assessment as well for all the testers. I actually developed a form. It's about 3 pages long, many steps that the site supervisors have to go through, witness the testing, and watch them from the setup of their workstation, the checking of the kits, temperatures, all of that, right through to the end of the preparation of the report. And then they sign off on it. Those forms come to me, I review them and send back a copy for their records. An extra step to ensure quality as well. Even though we have the trained testers and we have the reagents that are standardized and the standardized books, we also ask them to send 1 in every 10 samples that they test out in all of those testing sites out in the regions, and send them in for us at the reference lab here to check for HIV and syphilis, just to make sure that we didn't miss anything, right? And of course, a big part of my job is going out on audits. So if I can't make it, I will probably send one of those master testers to go in with a checklist to do an assessment, just to make sure that everything is on the up and up. We checked for the safety, because that's a big part of it. You're working with HIV, you must test safely. We look at the documentation to make sure it's complete. We look at the QC checks. Must test your controls on both kits, although the second kit is for just for confirming positives. A lot of people, you'll be surprised, miss the step of running a negative control on those kits. And of course, the section that us auditors refer to as witnesses, where we stand by and actually watch the testing process from beginning to end to ensure that no shortcuts are being taken, etc. We have other EQA programs that we participate in. I'd mentioned before. This is for the CE4. And at a glance, you can see that we have an excellent track record in our performance. What happens is all the samples are shipped to me from Canada, and then they're sent out to the various sites. They test, they submit their result sheets to me. I go through and review everything to ensure that all is well. And then I upload the results to the website by the submission deadline. When the results are ready, I download and review. I email back to the sites with suggestions for corrective action where necessary. But that's very rare. That's very rare, I must say. They're doing very well. We do other EQAs, as I said. We do hepatitis. We used to do HIV drug resistance through One World. That has been suspended, and I think they're doing it through another program that's supposed to be starting up shortly. Of course, I didn't add it here, but I'd mentioned that we also do genital culture and we do torch, which contains the herpes. All right, so this is our core immunology department. Nobody wanted to be left out of the presentation, so forgive the videos and the pictures, please. This is the department that does a hepatitis, herpes, and they also do ANA and all of those serological tests. And this is a serology department now. There's two of them. They do VDRL testing, TPPA, and also when the 1 in 10 quality checks come in, sometimes it can be hundreds of samples. They're the ones that run those checks. And we also do, through the CDC, syphilis, early infant diagnosis, and viral load. And as you can see, our track record continues to be excellent. The molecular immunology department now also factors into our testing. That's our Cobas 6800. That was our workhorse during the COVID pandemic. Since then, we got a Cobas 58. We are validating Roche Cyflow. We also use PIMAs because they have been, I can't think of the word right now, but they're not making the PIMAs and the fax presters anymore. So we are trying to procure some fax lyrics. This department is currently also doing testing for a national HPV project with support from Cornwall Regional, with that recently also received a Cobas 5800. So let me tell you a little bit. Although I may have mentioned some before, let me just go through some of the issues that we are facing here. So for the rapid HIV program, few sites are not following the national testing algorithm. Some have gone out and it's like they just go to the supermarket and buy some kits and they're doing testing. So I give them a flat 0. And of course, I turn up wherever they are. I go there and have a good talk with them. There has been some issues with procurement of the 2 kits that are currently in our algorithm. So we are validating some other kits so that there'll be more options. And of course, additional staff needed for the quality department because it's me, just one person. And of course, the electronic PT platform that is being developed and we're testing now. has been a great help. I don't have to sit and type 53 reports. It just spits them out when everything is done. And in the future, we're hoping to provide panels for individual testers, not just one panel per site, so that they can have more ways to assess competency of the analysts at the sites. For the rapid syphilis testing, that's done widely across Jamaica, but there's currently no EQA program. Reason being, one person can't do it. And the people that you see assisting me, they work in other departments. So when you see them assisting me, it's at nights or they give up their weekends. Viral load testing, we are looking to decentralize it. So NPHL will no longer be the only site that does it. Corner Regional just started, that's in Montego Bay. They just started maybe the end of last year. And some other sites are getting gene experts so that they can do some point of care testing there. So of course, there'll have to be another EQA program developed. So in the beginning, we'll start with the intra-laboratory comparison so that we have some idea that they are adhering to the quality protocols. And of course, for CD4, as I told you, they're discontinuing the Faxprestos and the PMAs. They have even stopped manufacturing the reagents and the kits. So while we are validating an instrument, what is it again? The SciFlow, we're looking to get 2 fax lyrics analyzers. And that's it. And this little video, I always have to laugh because it really, really speaks to the life of a quality coordinator. When you think it's all going well, something always goes wrong. All right. And on behalf of the team here at the National Lab Services, thanks for listening.
Thank you very much, Andrea. Thanks for the presentation that included some really nice videos. And indeed, that last video is it goes well until you come into, you encounter some obstacle or some challenge, no? So thank you very much, Andrea. Thank you, Valerie, for your very comprehensive presentations. I will open up the floor for any questions. If any participant would like to make an intervention, please open your microphone and speak. And while I wait on participants, Valerie, I'm sharing the results. So if you would like to take the questions one at a time and maybe just respond or react to them.
Well, Shanti, thank you.
Can you see?
Yes, I can see.
Wonderful.
Yes.
Go ahead.
Yes. And of course, the majority of the testing errors, you got it right. It's the pre-analytic area. You would have seen from the data that I presented. It's the pre-analytic area that tends to have most of the errors. And of course, you were also correct when it came to the actually, you were incorrect when it came to what percentage of medical error occurs in the diagnostic testing process. It's actually 70%. 70% of the medical error occurs in the diagnostic testing process. So this one, I think you thought there was a lot less than there actually is. Which of the following causes the most testing error? Yes, human error is the major cause of the testing errors, and you would have heard that from the examples that we talked about, etc. Number 4 here, which of the following can result from testing errors? And all of those can result. Delays in treatment, incorrect treatment, increased morbidity and mortality can be result. So all of the above was the correct answer as you selected. So that was great. And what is it required to ensure test accuracy and reliability? Implementation of laboratory standards to assure quality. That's the correct answer. Hiring technologists who have a lot of experience. It may help you, but in fact, you're not sure that the experience is as it should be. So it's really more about hiring technologists who have the necessary competence And using high-tech equipment in the lab, that is a plus in some ways, but we saw that a lot of the error is human error. Even when you have those very sophisticated systems, a lot of the error is human error. So implementation of those standards, the lab quality system, is really, really key. Okay, I think that's the end of this. We had some true and false ones, but I don't think they're here.
I wasn't able to program
Okay.
the salary. Yes.
No problem.
Yeah.
So I think generally you did pretty well on the questions. That one question there that you really didn't get a correct answer, number 2 here, where medical error occurs in the diagnostic testing process. It's like 70% of the error. So.
Yeah.
But thank you for responding and responding well. You did well.
Good job, everybody. Thank you, Valerie. I'll leave maybe 1 or 2 minutes for any burning question. If anyone has any question or any comments, you can open your microphone and you can make the intervention now. And while we wait, this is a kind reminder, kindly include in the chat your name, your profession, and your country. Name, profession, and country, please. Oh, let me stop sharing. Yes. Okay, so if there are no questions, no interventions.
Yes. And I have a question.
Go ahead. Who is this?
Dr. Cummings.
Dr. Cummings? Go ahead, Dr. Cummings. Please.
Right, yeah. Good afternoon. Valerie, it's been a long time I haven't heard from you. It's great to see you still in the system. Right. Good to see that you're still providing service to the people of the Caribbean.
Yes.
May God continue to bless you. Right. Now, I just want to ask a question in respect to the errors. Now, you're saying there's 70% errors in the diagnostic testing. That's very worrisome. So, can you comment on what is this within the Caribbean? Now, what happens, let's say, do you have similar data, let's say, for North America or Canada, the developing world, so that we can compare to see how far we are from getting there? And also, can you also comment? I know there was, people tend to blame COVID for everything. But is it, it's not just about experience, but because we must have a succession plan at some point, or new technologists or new technicians have to be given the opportunity so they can gain experience. So I'm just wondering if during the period when universities were online, and students might not have gotten the relevant or the sufficient amount of practical experience, if by any way, in your observation, that might have contributed to some of the inadequacies we see in terms of and the large number of the high percentage of errors that we now see. I just wish if you can comment on that. Thank you.
Thank you. Thanks, Dr. Cummings. Thanks for the question. And yes, I'm really happy to hear you. Good to hear you again. So I think we do need to make sure that we clear about the errors, because it's not that there are 70% of errors in the testing. It is that when you are looking at diagnostic errors overall in medical errors, 70% are related to diagnostic or processing of medical tests. So it's overall errors in medicine, and 70% of those are really related to medical testing. And they're not about only the persons who are testing. If you look here, you would see that there are some that relate to requests that are incorrect. There are those that are related to misuse of testing equipment and so on, which relates to the individual. But it's not all of it is actually just the persons who are testing. Remember, we had a couple slides. So this one says nearly 7 in 10 errors, medical errors, occur during the testing process. So they organized more than 3,000 patient safety adverse events or near misses and that were reported by healthcare workers. And 7 of the 10 of those errors were due to testing process errors. And when we say testing process, remember we talked all about those, pre-analytic, analytic, and post-analytic. And when we talk here, this particular study actually wasn't done in the Caribbean, and I will get to your Caribbean question shortly. This one was done in Thailand, and they actually said the most common error subtypes were incorrect test ordering. So it's not only what's happening in the lab, but what's happening before the lab is also part of what is actually creating testing process errors. So we need to be clear about that. And of course, the specimen collection, of course, is yes, the responsibility of the lab, but that test ordering is precedes the lab. So that's one. The other one is that this data is all international data. This one was Thailand. The previous one was the US in terms of a US study with the Emergency Care Research Institute. And of course, these examples that I provided were from the UK and from Uganda and from the US. So the point is that lab error is a very real thing, and that it's not every test that has an error. What we're saying is, though, that 70% of the errors that arise in the medical field are related to testing errors. And some of that testing error is actually related to even before the test reaches the lab, the ordering of the test, 48.2%. Yeah.
Overall,
So it's not to say that 70% of the tests are erroneous. No, that's not what we're saying. We're saying that 70% of the errors that occur overall in medical errors are due to the testing process, and that includes even test ordering. Okay, so that is what is being said. And in fact, we have actually done work in the past that verified that for our Caribbean area, that we actually saw data that showed that we had similar kinds of error in that pre-analytic area. For example, we were able to identify we had those kinds of errors that were arising. So I think we haven't done any recent study, and that's why I didn't produce any, put forward any information that was from a study in the Caribbean, because we haven't done anything recently in terms of studying those kinds of errors. But I just wanted to clarify that, and I'm glad you asked that question because it helped to clarify the information.
Yeah. Thank you very much, Valerie. That's a really important clarification. So thanks for that, and thanks to Dr. Cummins for asking. Colleagues, we will wrap this up now. Thank you all for being with us this afternoon. Go ahead, use your reaction button. Let's give our presenters a round of applause. If you go to your reaction, yes, thank you very much. Thank you, Valerie. Thank you, Andrea. 2 comprehensive, in-depth practical presentations on laboratory systems and how we can strengthen laboratory systems, not just for EMTCT, but overall. This, colleagues, brings us to the end. Just a few points before I close. One, I will send to you the 2 presentations. So if you have time, you can spend some time, look at the slides, review what has been shared with you. Please feel free to share the slides with your colleagues as well. And so you will receive those 2 presentations as soon as possible. You will also receive a post-event evaluation, and I encourage you to give us your feedback. It's a very short survey, maybe 5 or 6 questions that are like multiple choices, tick the box. Please give us your feedback. We'll appreciate that. And do look out for our announcement for the next webinar. It's always a pleasure having you with us. And so that should be coming out in very short notice. This is it for now, colleagues. Good afternoon and have a good rest of the day.
Thank you. Thanks, Shanti.
Thanks, Shanti, and thanks, Andrea.
You're welcome.
Thank you, Andrea. Andrea, please send
Thank
me your
you.
slides.
Thank
Yeah, I'm
you.
up some errors that I saw and see how I can transfer it to you.
Okay.
It may not be via email because it's quite big.
Thank
You can
you.
probably do it.
Thank
Yeah.
you.
All right.
Bye-bye.
Thank you. Bye.
Bye bye.